So I'll be taking you through implementation science today, and I will give a short introduction of this topic. And I hope maybe by the end of this 1 hour, I have nothing to disclose, but maybe we'll be able to do some introduction on implementation science, theories, models, and framework, and we'll go through a little bit of strategies, but also on the implementation science designs, and I hope that we, by the end of this talk, we'll be able also to know the implementation science outcomes, which is somehow different to the ordinary implementation, study outcomes that we have been studying over the course of this lecture series. So as an introduction, there is a lot of evidence that have been produced, and the problem is that most of this evidence are not being put into practice. For example, these studies have shown that more than 50% of patients do not receive the recommended care. So what is recommended by the science, but also by the practitioners, does not reach the patient that we aim to target. But also the spending is very high. Most of the medical, nearly 30% are unnecessary, but also if you look into specific things like surgical safety checklist, which has been proven to improve the outcome of patients, these are not being put into practice. So less than 30% are put into practice. And also optimizing patient care requires closing this gap. So what we know and what we do in our practice, but also what we do in our policy, that is what we are supposed to achieve. So we know that we do have a number of problems, diseases, the burden of diseases, but also maybe poor outcomes of our patients. And we also do have efficacious interventions. But the problem is that there is a huge disjunction between what we know, the efficacious intervention, and the significant problems. These interventions are not put into practice, and that is what brings to the problem of implementation. That is where we want to target. And even evidence, for example, if you look into the COVID-19 shown that most of the intervention could be put in place in quite short time. But the problem was the same, that what we used to know, easy things like even hand washing, was not put into practice, and that resulted into an increase in the disease burdens. So implementation science, this is the study of methods and strategies that promotes the uptake, so the systematic uptake of these proven interventions into routine care, into routine clinical practice, and we look into issues that will influence our behaviors, influence the way we do things, to make sure that what we know is really being put into practice. And implementation can take part in two ways. It can be dissemination, or it can be implementation. And in that way, it can also be the dissemination practice. For example, implementation practice, this is how we do things. For implementation is how we do things, how we put the evidence that we know into practice. But if you look into the science of it, this is the study of which method, which strategy, or which strategy can be useful to make sure that the innovation or the intervention that we are targeting is being put into practice and policy as it is intended. And if you look into dissemination, this is how you want that innovation to reach the people or the provider, so the target population that you want to aim. So if you want to practice dissemination, implementation of an implementation, you can say, okay, I will use social media, or I can use maybe WhatsApp to reach the target population that we want to achieve, to aim to. But if you want to do the science of dissemination, then you have a number of methods that you want to see which one is effective to make sure that that innovation that you are targeting to reach people is really which method or which strategy is useful compared to the other. And Quran and colleague in this study, they published and tried to make implementation science in simple language. So they called the innovation or the intervention that you want to put into practice as the thing. And that thing can be, if you want to study its effectiveness, how best it works to address the problem that you want to target. So that is the effectiveness of the thing as an intervention or an innovation. But then you can say, okay, implementation research is also looking on how best to help people or places do the thing. So this is actually speaking to how best now you put that innovation or intervention into practice. And to do this, to make sure that the thing is being put into practice and people and place have adopted it. Then that is we look into what are the strategies, what things need to be done, what things need to be changed to make sure that this thing is being put into play into practice and to achieve the effectiveness that it is intended to reach. So if it is patient outcomes, if it is to reduce the complication of patients, then the main implementation outcome is how much it's beyond the effectiveness design that we have been using, but how much and how that the thing is being done, how well it is being done, and to make sure that the intended outcomes are being achieved. So if you look into this example, it looks into beyond the outcomes as effectiveness, but also outcomes on how best the thing can be done. What are the strategies that can be done to make sure that that thing or an intervention is being put into practice? And most of you could know, maybe over the course of this study also, this lecture series, could know that research can evolve in a number of stages. So from the basic or preclinical stages to the T4, where the innovation or an intervention is being put into a bigger population. So this is how the continuum or the research pathway looks like. But implementation science look into these later stages where you are now trying to make sure that that innovation that you are targeting is really reaching a bigger population. So T4, I mean T3, where it is maybe in phase 4 of clinical trial. We will look into this more in detail, but also mainly to make sure that that innovation that you have or that knowledge that you have learned is reaching people in a broader perspective. So again, you will see that if in implementation science you look into how many people you reach or how wide the innovation reaches and how much it is sustained in the system, and you look into more of the external validity, how much that innovation is bringing the intended outcome in a bigger population rather than in a very controlled design as in this initial stages of science. And it's not anything that can if you want to do implementation science, it has to be specified. You need to specify the intervention. It has to be evidence based, and there is a number of measures that have been put in place to make sure that you assess an intervention to make sure that it is fit or it is ready for implementation. Because for that one, you want that innovation to reach more people or that intervention to reach more people. So it has to be safe, it has to be effective, it has to be patient-centered, it has to be timely, but also efficient and also equitable. So it has to be to meet. This is how it was designed by the International Institute of Medicine, but also the grade system can also be used. So when you now want to you can now design your study and define whether it is an efficacy study. This is when an intervention has has the intervention or practice, if it has not been proven, if you don't know the efficacy, that is in a very well controlled environment, maybe mainly in lab-based studies. So if that in intervention that you want to put into practice, it has no efficacy studies, then you have to do efficacy kind of design. But this one is not mainly implementation. But if it has efficacy has already been proven, then you can move with it to see whether the effectiveness has been proven. And now, if it is effective, now that is when you can think of doing more of implementation science. And as we will see later, you can take a different approach, whether you look into effectiveness in a bigger population or in a new population, or you do both, where it is a hybrid design where you look into both effectiveness of that intervention as well as its implementation outcomes. But also you can also do mixed methods, and most of the time you can say, okay, it is more effectiveness, it has already been achieved, and my aim is mainly to look into how best it can be put into place. So you focus mainly on the implementation outcomes. So we'll see this later, but what I wanted to insist is that not every innovation or every intervention can be put into implementation design. It has to be staged. It has to be proven to be effective before it is being put into practice. And then there is a number of languages that have been used in implementation science. And this is to try to model, to make sure that what we want to implement, since it is affected by a number of things, a number of factors, then there can be theories. This just describe a causal relationship, that one, if you do A, maybe that can result into B. For example, it can be capability, opportunity, and motivation. So if someone is capable of doing an intervention, then he is more likely to do it. And if that intervention, if he does that, then it can result into good outcomes. So that cause and effect relationship can be determined by theory, and we'll see also later. But we do have models as well. This is a simplification or a simplified theory that could tell you step by step on, if you have an intervention A and your outcome is B, then what are the small steps that can be taken to reach into that desired outcome. But then we also have frameworks. These are factors that believe to influence an outcome. It doesn't look into the causal relationship, but it does not tell you how to do things, but it tells you what to pay attention to. So if you want to, for example, this is very common. If the REM, this is reach, effectiveness, aim, and adoption, implementation, and maintenance. But very common, the CIFAR model, the CIFAR framework, which is saying, okay, maybe you have to look into the context, you have to look into the characteristics of an intervention, you'll have to look into outer and inner settings, etc., etc. So this is a framework. But you can also say, you can also be in mainly in it's very common also to use them as all. So you can combine maybe a theory and a framework, and that you call an approach. So this is just where you put your methodology. You can call it an approach, where you see that you combine maybe a theory and a framework. Maybe you can also combine a model. For example, knowledge to action, how you produce your knowledge until the way that you evaluate them. So you can call it as an approach. And for this one, they are described in three groups, and these are really based on the kind of a question that you want to respond. For example, if you want to just describe a process of how you are translating your research, or that how you put that innovation or intervention into practice. So that process, you can use process models. But if you want to understand what they are, the influences, what influences the implementation outcomes, so and what are the barriers, you can have this kind of framework. You can have determinant framework, classic theories, but also implementation theories. And we have specific theories that are looking into how you want to evaluate your implementation. So this comes maybe in a stage where you have already intervened, you have already put your implementation into practice. Now you want to evaluate. So there is a list of frameworks that are looking into the evaluation of that implementation process and determinants. But then the theories can also be further categorized based on their origin. But most commonly, the origin of implementation theories, these are really inherent from the implementation science. But the classic, these come from other specialties. For example, the social cognitive theory, and as well as for example, if you want to determine also, sorry, specify the determinant which act as barriers and enablers. So these are the depending on what you want to understand, you can have the theories. But I wanted to show this figure, this table here, which will really guide you. There is a lot of frameworks, but these are the most common ones that you can use. And if you want to do, maybe to understand the barriers and the enablers, these are, you can use any of these theories. If a COM-B, for example, this is capability, a behavior model. But also you can use CIFAR if you want to look into the context as well. So it's broader. So this table just guides you which, because we have a lot of theories that maybe I will not be able to cover in this 1 hour. But if you want to design implementation strategy, you can use a behavior change wheel, or the theories can be useful. But if you want to assess the implementation context, where your implementation is being done, it's very common to use this FAR model. So these are the common theories that you might end up using in your implementation practice if you decide to use implementation science. And if you go now, next is that you have your intervention, you have your innovation that has already been proven to be effective. And you will need to now design what are the strategies, what things need to be done, what things need to be done differently for you to be able to achieve the desired outcome of that innovation. So we call them strategies. There is specific framework that you can use to guide you, because there is so for example, the ERIC framework, this has already, so the expert recommendation for implementing change, this framework have a list of strategies. So they also help in terms of nomenclature. So if you are doing that study, for example, in Tanzania, the other person is doing in say Uganda or Kenya, you will have the same language. If you are targeting a certain behavior, or you want to achieve a certain intervention, for example, if you want to use maybe training, if you want to use maybe to restructure your environment, so this framework just help you to have that taxonomy to make sure that things can be used in a very common way. But this is an app as well. It's a mobile app that you can use, and it is more of the behavior change. So you can look into your innovation and see what are the challenges. For example, if you are looking into a goal and planning, maybe you can click that in your mobile, and then it will give you a number of possible strategies that you can use. For example, if you want to, so this will just make sure that it is common, the way you use it in any place, it can be also used in another place in a very harmonized way, or I can say it is like a taxonomy for you to use, and make sure that implementation language is also clearly understood at every setting. So as a summary for the implementation science, we start with what is the problem. You know that there is a problem. Maybe I can say maybe there is a huge rate of HIV, and you know that there is an evidence that has already been proven. If it is maybe to change the behavior of people, to make sure that they follow, they adhere to the medication, but so your medication is the intervention. And then you know that the barriers and facilitators, these are, for example, the behavior changes that will make this innovation, this intervention, if it is a pill, to be used in a very effective way for it to address the problem in practice. So what are the issues? What are the challenges? And when you know these barriers, when you know these facilitators, then that can guide you to design what are the strategies, what strategies I can use to make sure that the change or the improvement in the health outcome that I am intending, they are long term, but also sustained in the practice, in the practice or in my environment. So when you come from the barriers up to the long term, this is when you now start to scale up your innovation, and you also evaluate your implementation. But also over this whole process, you will use a number of theories, models, and framework, and mainly to understand maybe the barriers and facilitators, to design your strategies, but also to evaluate and think on how best you can achieve the outcomes that you are intending. So what behavior need to be changed, what behavior need to be addressed, what maybe sort of environment need to be changed for you to be able to for an innovation or an intervention to be able to reach its desired goal, desired outcome. So we do have this kind of designs that we have looked into over the course of this training. But when we start now to look into randomized clinical trial, I think that will be mainly the question: why do we have to do implementation? As I've said, one reason is for you to make sure that the innovation, you also look into the resources that you have, but also the ethical issues. If an intervention has already been proven to work, there is no need to randomize other people to make sure that some receive the innovation or the intervention. Some are also randomized, even though it is in a new setting. Probably the ethical challenges, and now with the changes in the medical landscape, we have access to information in a very timely manner. So there might be ethical issues, but also mind you, those also social issues. Our patient keeps on learning and knowing most of the new innovations as well. So you come and you'll be challenged by the patient. For example, you want to do a study and you want to randomize them, for example, in a new a drug. That is okay. You want to study the effectiveness, but if it has already been proven to be effective, that is when now you consider doing your new design, which is implementation science. So these are the most common kind of designs that have been used in implementation science. And a cluster randomization, this is one of the method that you can use, because your unit of randomization is not at individual level, but it is at a cluster level. So if it is a hospital, the hospital receive an intervention A, and another hospital receive an intervention B. But if you know that an intervention A is already effective, eventually you will want to go and make sure that after that comparison, then you roll out a new innovation or a new intervention. And this can also be complemented by a stepwise design. This is when now you introduce that intervention in a new setting, but in a sequential manner. Maybe it's because of the resources, but ideally what you want to do is that you want to reach you want the innovation or the intervention to reach the people that you intended to do, but also mind you that in terms of evaluating whether the intervention is ready for implementation, there was also issues of equity. So stepwise design is taking place, but in a way that at the end of your design, you are able to reach all the people. Everybody has, if possible, can be able to access the intervention that you are intending. So it can be a cluster randomization can be a parallel like this, where you have your 1, 2, 3 sites and the 3, 4, 5 as controls. So all of them, they start together. The parallel design will now compare these clusters where the intervention has been when they are being exposed into an intervention versus those which are not exposed into an intervention. But you can also, now that is when you need a statistician, you can also do the comparison within the groups, so maybe group 1 and 2, because also implementation science is being affected by the context. So maybe context A, context 1 and context 5 could be different from context 1 and context 5. All of this information will give you power to make sure that when you want to enroll to roll out your intervention, then you have full information. You have both effectiveness, but also you have implementation science, implementation outcomes. You can also do a parallel study with baseline period, where you start all of your 6 sites, you collect your baseline information, and at a certain point in time, you now come back to these 3 clusters. You introduce them with an intervention. So in the end, you'll be able to compare the clusters before and after the same clusters, but also you can compare those which have been exposed to the intervention compared to those which have not been exposed. And when you look into the stepwise design, you have your 6 sites and you have a certain period. For example, this is so going horizontally, this is time and these are the clusters. So you start by collecting baseline information in all of those sites, and then you say maybe at month 1, you start introducing a new intervention. You expose the first cluster with an intervention, and it continues endlessly. But every time when you introduce, for example, it has to be also sequential. For example, if it is every month you introduce a new site, all the other site will come, you will collect. So for example, here this is month 1. I've introduced in cluster 1, but I will collect data in all these clusters. So you can already tell that this is a very complex design in terms of the statistics, but when you plan it very well, a statistician is able to compare the intervention effectiveness between these clusters, but also within the clusters. So you can roll out in a stepwise design, but also you can have a washout period, a transition period, where, like in D here, you start with collecting your baseline information, and you have a washout period before you start innovation, you rolling out an intervention. For example, maybe there might be some, you can have maybe initially there is already an intervention or a drug that has been used, and you really need a certain time for it to phase away, for you to be able to start over in a new drug to avoid interaction. So you have this washout period, but in the end, you see that in the end you have all the clusters introduced to the new innovation. So this is just another example, the same. This cluster have been selected randomly, and with time, each of the cluster has been put into an intervention randomly. And at month 8, you see that every site, every every site has been put into a new intervention. So that is stepwise design. The aim is to reach your population at the end of the innovation, and to make sure that the intervention they are able to gain the intervention outcomes. So that is the desire of the science that we do. We want to improve the outcome of our patient, but we will see later that this is just an outcome effectiveness, but in the design you have also to collect outcome data, outcome, which I mean like effectiveness, not only effectiveness, but also implementation outcomes. So this is where you can have another design, which is a hybrid design, where you have your clinical research, but you have an effective intervention, and you can do hybrid type 1, where you want to study your focus, your primary focus is to study the effectiveness. For example, if it is to use the surgical site infection, your target is surgical site infection, and your intervention is the WHO surgical safety checklist. So here you are looking into the rate of surgical site infection, but also as a secondary, you are looking into what are the feedback from the providers who are using this surgical safety checklist, the WHO surgical safety checklist, and see whether there is anything that they can add for you to make sure that after this effectiveness design, then you maybe you also learn about the implementation challenges. Maybe there can be context. Maybe they want it to be printed, or things like that. Or if it is an intervention, maybe people who takes if it is ART, for example, for HIV, the effectiveness could be the viral load that you can look, but also you can look into the behavior, maybe when a patient will take maybe a single pill, or at a certain time of a period, that is when they take more. So in the end, you can also move into the hybrid type 2, where the focus is equal. This does not mean that it is sequential. You can choose to do this in your study. You can choose to do depending on what is your interest. But more the implementation research looks into hybrid design, and that one is in the aim that you already know the effectiveness after all this kind of design, from the randomized trial to effectiveness, the hybrid type 1 to hybrid type 2. You see that the implementation strategies, the effectiveness is okay, but you need to only change the implementation outcomes, what things can be done to do things differently for the outcome to be achieved. But also, so here the focus is no longer effectiveness, as we'll see. You just want to focus on the implementation strategies, and to make sure that there is a improvement in the implementation outcome. And for that one, you know that if implementation outcomes have been improved, then you are able to reach your targeted goal. You can also use the quasi-experimental design, and for this one, you try to make a control and a comparison, so a control and an intervention group. Uh, this is similar to what we have looked into the stepwise design. You have the time of pre-post, before and after. Maybe your intervention is training, so you collect the information, the baseline knowledge, and then you intervene here, and then you do your follow-up and maybe collect the outcome, the knowledge after the training. That is, you know that people will do better. You'd use the because they know they are trained, they know things, how things are done, so they can improve. But you already know that this is normally short time, and you there is a number of biases here, but sometimes you can use with a comparison group, where before and after, but you also have another group where you don't do any intervention. So in that design, you have to compare this one, the first group, before an intervention and after the intervention, but also you are able to compare with this new group where you didn't do any intervention. And for this one, you if it is rate of infection, then you know that in this first group there will be lower or reduced rate of infection, but this one will stay the way it is because you haven't done anything, you haven't introduced an intervention. But also you can stagger this in a number of times. So you can say you collect in a monthly basis after. So this looks like a normal quality improvement project where you see the change, but this is after time. So this is an interrupted time design where you collect baseline information in a number of times. So if it is month 1, 2, and 3 and 4, this is only to collect the baseline information. And if it is again rate of infection, we expect that at month 1 and month 4 there will be no change. But then at month 5, that is when you introduce your intervention, and then you expect that after this introduction the rate of infection will lower down. But then you expect that with time even it should go also even lower, because for example, more people now start doing that, the new way of doing things, the new ways of reducing infection. So that is also telling you a number of reasons that maybe your implementation has been uptaken has reached more people. So it has been also being adhered by people. So this is how it will look. Maybe these are the 4 months before the implementation. Everything, the slope is just slant. But when you introduce an intervention, then you expect a change. But then with time, you see that even lower and lower rate of surgical site infection, for example, it will go down and down. And that is not only so the issue here is not only the effectiveness of an intervention. The intervention is already effective because when you introduced, you could see a significant change here. But then the issue was implementation. So as people who are taking this intervention, taking it, or it is being integrated into the system, then the outcome or the impact is even getting bigger and bigger. So I wanted also to touch into implementation outcomes. These are the issues that I was saying. So maybe with time, people have accepted a new way of doing things, a new way of improving surgical site infection. But the fidelity is also looking into the way it is done. If it is a surgical safety checklist, apologies, I'll be using this surgical interventions just to illustrate an example. But if it is a surgical safety checklist, the way it is done, then in a new setting, everybody is doing the same way in a very correct way. But also there is effectiveness. This is where most of our design will focus. And sometimes for implementation science, this is not mainly the focus. It depends. For example, when we were speaking about hybrid, if it is hybrid 1, then this is the focus, but you also look into other implementation outcomes. This is the focus because you want to prove that new innovation, how it works in a new setting, but you're not randomized anybody. You are just doing, for example, the cluster, as I've said initially, the cluster randomized, but also you look into appropriateness. Is it feasible to use that surgical safety checklist? You can take an intervention, any intervention that you think about. Is it feasible, for example, to use insecticide nets? For example, if I change to that, are the people using the same way? We have stories where people had beliefs and didn't use the insecticide nets in a proper way. So this is a key outcome that we need to know, make sure that we maximize or we increase the impact of that intervention, which here is the insecticide nets. And is it feasible to use the implementation cost? So you look into issues of cost, because you don't want to introduce an intervention even if it is effective, but it is also it can only be reached by very few people. But also you look into penetration. You look into penetration in this manner. For me, I look mainly, for example, if you have trained a group of 10 people, and after time, you know that 10 people will also share that knowledge to the other, because the other have accepted that innovation, then it will keep on penetrating to the population. And maybe when you come back and do a post design after some time, that is when you know even the knowledge of the rest has already been increased, so that you can tell that the penetration is also very high, but it can be influenced by a number of other implementation outcomes. We also focus mainly on sustainability. Implementation science, rather than focusing on ethical to make sure that it is equitable, intervention can reach more people, but you also want to sustain. You want to sustain. You don't want to introduce an innovation in a new setting for the sake of the project, but you want it to be sustained for a longer time, whether you are there or whether you are not there. It has to penetrate the system. It has to be taken by for example, the leaders, the government, or the hospital administrators, so that so they accept it. They also maybe arrange some budget for it, or even patients, they accept it, and they are able to pay for it. So it takes you away from a single project to a sustained outcome of that intervention. So this is how where we start. We have a problem, but also we have an intervention and evidence-based practice. But also we need to know how to do things. We know the how to do the what. That is the strategies. For example, here you can say they can look into various environment, but also they can focus into patients. And then you start now collecting your outcomes. So we focus mainly on effectiveness, as I've said, but there is a range of outcomes. You can say, so this figure by Proctor is only showing that if you are able to use strategies to be able to reach these implementation outcomes, you are very sure that even the clinical or the client outcome will be also achieved. So if your target is satisfaction of patients, if you change your innovation and then it is feasible, it has penetrated in the system, eventually it will result into good patient or service outcomes, and then even client outcomes can also be improved. So this is where we want to take from the evidence. We want to put it into the whole process here of research to make sure that it achieve the implementation outcome until the service as well as the client outcomes. So this is where the implementation science is about. But around it, you have to also understand the context where the implementation is being done, because the intervention can be very effective, as I've said, but the context, the issues around, are the people accepting it? Are they perceiving that intervention as we found this when I think we were working on clinical guideline for cancer. You say, okay, you target, you say, for example, for breast cancer, you want to use this kind of medication, but it is not there, so that even the availability can change, and you can't put it into a guideline, something which is not available. But also uh, all this environment, as I've said, you want to sustain, so you have to look into internal structures, external structures, but also that is beyond the characteristics of an intervention. And this, again, I just wanted to highlight, this is the revised Declaration of Helsinki. I think we looked into it in our ethics session. This is looking into community engagement, but also so community engagement as key partners. These are the key group that will feed into your implementation. So if you want to target this community with a certain set of intervention or a certain set of strategies, you have to consult. Even so, the code design has been highlighted, but also the ethical oversight. We saw that there is a randomized clinical trial, but you sometimes have more, you have an intervention that has already passed through the RCT. It has already been proven to be effective. So you want to see whether it has outcomes. Mainly, you want to study the implementation outcomes, maybe the cost, the feasibility, the acceptability to the population. So you don't have to randomize these people. And this ethical revision, the declaration, I think they focus on this as well. The ethical oversight could look into this, not only to look into the implementation outcome, effectiveness outcome, but also the implementation outcome. And I would like to end with this summary of the key ingredients of implementation science. And this is also important as you look into or you want to write a proposal which you want to do an implementation science design. So you need first to understand that there is a problem, maybe a problem with in terms of access or in terms of quality. But also you for example, if we start with access, maybe people in the rural settings are not able to reach care in a timely manner, but we have evidence that we can use electronic, for example, maybe mHealth intervention that has been used, for example, in India, and it has proven to have good effectiveness in terms of access, that it reached it helped an intervention that you are targeting, the population that you are targeting to reach to receive that care. So that is access. So but also you see that there is an evidence already. You look into the conceptual model, and that will be informed by the framework, the models, and the theories that we have looked into. Whether you want to also engage the community, the stakeholders or the community. So engagement is key. How you want to engage the people that you want to target or the population that you want to reach. Is the setting where you want to intervene. If it is maybe same M Health, and you want it to be used by using phone, does the people or the provider have the means to use that intervention? So you look into the setting and see how this is ready, and we have frameworks for this also. So mostly the implementation science is guided by a number of theories, framework, as I've said. But also you look into, okay, all these other things are okay, but you want to see what are the strategies. You can code, you can have an idea of what strategy that you want to use, for example, but also you can also design them together with these stakeholders. So all the things has to appear in your implementation science proposal. But also the team, what team do you have, the expertise they have, and how much do they bring in terms of the effectiveness, the intervention that you want to put in place. But also how influential can they be in terms of making sure that this strategy are maybe context relevant, socially acceptable. So those people, for example, if it is in a community where people are not, you want to co-design with the community which doesn't speak a certain language, so it has to be reflected in your team. But also the feasibility of a proposed research design. So the design, do you want to use implementation rich, for example, hybrid type 3, or you want to use a hybrid type 1, but also you have another kind of design. For example, the quasi-experimental designs, but you also so you describe it as well in your methodology, and how are you going to measure your analysis? How is it going to be done? So this is also key, because you'll also look into what data that you are going to collect. So you have to say whether things like feasibility, acceptability, they can be collected by qualitative design. So you will already see that implementation science usually uses mixed method, but also in your analysis, one will want to see your outcomes, will want to see what outcome do you want to measure, and what policy or funding environment. So in the end, you have your policy changed. So this will really tell about the sustainability of your intervention, but also the funding environment, whether that has been achieved or you have the means to make sure that that can be achieved. So these are the key ingredients that you need to think about as you look into your implementation science design. So thank you so much.